So good afternoon, everyone. My name is Melanie Cavalier, and I'm the Chief of Innovative Care Delivery at the Maryland Healthcare Commission, or MHCC. The MHCC is pleased to present the MHCC MDAFP MedChi 2024 Summer Summit Mental Health Collaborative Care, Navigating Key Tasks and Roles as part of our Learning Network initiative. This event marks the 20th learning event over the last 3 years. The sessions aim to enhance the knowledge, skills, and competencies of practices to deliver equitable, comprehensive patient-centered care. This event is being recorded. The format for today's event is intended to promote an interactive conversation. We will start off with a couple of poll questions and we'll display thought-provoking questions throughout the presentation. To join the conversation, you may raise your hand or enter your thoughts and questions into the chat. For those of you who are not familiar with MHCC, MHCC is an independent state regulatory agency that supports advanced care delivery and practice transformation. We collaborate with payers and providers to transition to quality-aligned, value-based care and to harness the potential of data in facilitating meaningful change. Next slide, please. So this slide outlines important information about CME credits and disclosures. Following the event, you'll receive an email that includes a link to a questionnaire. The questionnaire requests feedback on the symposium and an application for CME or continuing education credit. We would appreciate your feedback, even if you're not applying for CME or CEU. So, this just talks about what type of credits available and that the planners and reviewers did not have any relevant financial relationships to disclose. Next slide, please. So today's learning objectives include identify treatment approaches in mental health collaborative care model, recognize approaches for crafting an effective treatment strategy within a collaborative mental health care framework, and learn techniques for defining the roles of primary care and specialists as part of a mental health collaborative care team. So I'm going to start off by asking a couple of poll questions, which include what is your practice specialty, and are you currently participating in a mental health collaborative care model? So can you guys see the poll questions? Can you guys see the poll questions?
No. No, the poll question is not up.
I see the learning objectives.
Yeah, sorry, that's okay. We'll just ask this a little bit later. So I'm going to start off with the opening remarks from Colleen George. Oh, sorry, next slide, please. So today we'll start off with opening remarks from Colleen George of MedChi, and then I'll provide an overview of the current Maryland landscape and select MHCC transformation activities. Next, we'll have 4 speakers that will talk about their perspective on our main topic. We'll hear from Dr. Iris Lepla from Johns Hopkins. So Dr. Lepla wasn't able to join us live today due to a medical emergency, but we will be able to hear a recorded presentation. Our other presenters who are here live today include Dr. Colleen Schrepfer, the Senior Medical Director of Gladstone Psychiatry of Wellness, Dr. Buana Bahithi from Dr. Bahithi Internal Medicine, and Dr. Hugum Passanello from Private Psychiatry Practice. So next slide, please. So I'll turn it over to Colleen to proceed with the opening remarks.
Good afternoon, everyone. Thank you for joining today. For those of you who don't know me, I am Colleen George from MedChi. One of my roles is Director for the Private Practice of Medicine. So I deal strictly with private practice physicians. So in that role, if you ever have any issues or questions that you want to forward to me, I'm happy to help out. MedChi is always happy to support the work of the MHCC and especially these educational webinars. A lot of hard work has gone into this presentation on the part of MHCC and the practices and the practitioners that are participating. So thank you to you all for your willingness to take the time to create these presentations and for presenting them today and giving your knowledge, vast knowledge, to all the participants. So thank you all and enjoy the presentation.
Okay, so next slide, please. So what does the Maryland landscape look like? We have 6.18 million people and 16.9% of the population, sorry, is over age 65. Next slide, please. So I'll now provide an overview of select MHCC practice transformation initiatives designed to support the Maryland model goals by readying practices to participate in value-based care models. Mental health care collaboration is a key part of that transformation. Next slide, please. So advancing practice transformation has been an MHCC strategic priority for more than a decade. The first practice transformation program was the Maryland Multi-Payer PCMH program, which ran from 2011 through 2016. The MHCC then partnered with MedChi, the University of Maryland School of Medicine, and the New Jersey Innovation Institute to complete activities in Maryland as part of the Transforming Clinical Practice Initiative from 2015 to 2019. This was a federal initiative that included over 124,000 clinicians. The MHCC has also contributed to planning and policy development for the Maryland Primary Care Program since its inception in 2017. Next slide, please. So the MHCC convened a Health Equity Practice Roundtable in March of 2022 with representatives from advanced care delivery practices. The goal was to achieve advance health equity through development of practice resources informed by roundtable feedback. Feedback from the roundtable informed the symposium in March of 2023, which focused on strategies for identifying patterns of need in the community, building referral networks for services related to social needs, and connecting patients to resources. More information about the HE Roundtable is available on the MHCC website at the link on this slide. Next slide, please. So in June of 2021, MedChi CTO was competitively awarded a grant to complete practice transformation activities. A crucial role of MedChi CTO is providing practice coaching on specific transformation topics and approaches to help sequence and model change essential to succeed in a VBC model. The program milestones include a readiness assessment, workflow redesigns, and training. Approximately 45 practices completed the program in June of 2023, and an additional 27 are projected to complete the program by June of 2024. We're accepting applications for this program, so please reach out to me if you're interested. Next slide, please. So the MHCC convenes peer learning network events like this one in collaboration with local and national healthcare leaders on topics such as health equity, advanced care delivery, and practice transformation. More information on learning network events is available on our website at the link listed on this slide. Next slide, please. So two recent events include the Health Equity Symposium I mentioned earlier and the evolving role of social workers in team-based advanced care delivery. Next slide, please. So I'm now going to play a recorded presentation from Dr. Idris Lepla. You may send me any questions and I'll route them to her. For those of you who weren't on earlier, she's unable to join us due to a medical emergency.
Hi, I'm Idris Lepla. I'm a medical director of the Consult Liaison Psychiatry Service at Johns Hopkins Bayview. I'm also an attending psychiatrist in the Collaborative Care Center and an assistant professor of psychiatry at Johns Hopkins Bayview Medical Center. So my talk is called Whack-A-Mole, and it's navigating the pitfalls of primary care psychiatry, just because there's a lot of great best practices about collaborative care psychiatry, but there's also a lot of challenges that I've had. And I'm going to be talking about some of the best practices, but also some of the challenges, and hope that we can brainstorm together how to get through them. Next slide. I have no relevant financial disclosures. Next slide. So my objectives, I wanted to discuss the Johns Hopkins model for collaborative care in the outpatient setting. I want to illustrate the model with some instructive cases, point out some difficulties in managing these patients, and also, talk about, is it the model or the patients that make this process difficult? So next slide. So this is a diagram of what collaborative care is. So collaborative care is any time that a psychiatrist and a medical doctor or PA or NP are discussing a case about a patient, and the model can be that it's just co-located care. So for example, the patient is in the clinic and they're seeing the psychiatrist and the medical doctor at the same time, perhaps back to back. It can be that the med doctor and the psychiatrist talk about the patient, and the medical doctor alone implements those recommendations without the psychiatrist ever seeing the patient. It can be the medical doctor talking with a social worker that's especially versed in collaborative care. So collaborative care means a lot of different things. Co-located care is one version of collaborative care, but really the kind of best practice model for collaborative care is often that the psychiatrist doesn't have any direct contact with the patient. Instead, the medical doctor gets some consultation from the psychiatrist, but the medical doctor, using that consultation, then directly treats his or her patient. Next slide. So best practices of collaborative care are that it's population-based, meaning that you take a population of patients and they're all in a registry, and you measure their, let's say, PHQ-9, which is a depression rating scale, or GAD-7, which is a generalized anxiety rating scale. You track those measurements over time. The patients that you track are in this particular registry, like in an Excel registry, and you use measurement-based care to see how those patients are doing with regards to the collaborative care they're receiving. So if, for example, a psychiatrist consults on a patient day 1, you would measure a PHQ and a GAD-7. You would track that, 4 weeks later, 8 weeks later, and that would be the same for all of the people in that registry. So the outcomes are very population-based. How did the population do overall with the collaborative care? It's not necessarily based on individual patients, because there can be some individual patients who do quite poorly, which I'm going to talk about, whereas a population itself can do quite well, especially in terms of depression and anxiety scales. Next slide. So this is a slide from the Ames Center at University of Washington. This is a very busy slide, but I wanted to show you that at 12 months, they felt that based in the population, so again, taking the entire registry of patients, that there was a 50% or greater improvement in depression at 12 months using collaborative care. So collaborative care in this model was that the PCP would consult with a psychiatrist, and then the PCP would treat that patient, and that patient would be followed by a health behavior specialist, who would have very close monitoring of a registry of patients. So like a group of patients that were monitored over time. And in usual care, so that included referral out to a psychiatrist, or no treatment, or the PCP prescribing without a psychiatrist, the patients were significantly more depressed. So this Ames Center, it's a great resource. It's from the University of Washington. It has a lot of best practice guidelines for collaborative care. And if you have any questions about what collaborative care really means, you should go to this center, and you can access it online. Next slide. So I just wanted to show you that Hopkins is part of a greater network involving Baltimore, but not just Baltimore, Maryland, the entire, all the counties of Maryland combined. So the Center for Medicaid and Medicare, the CIMS, has a program called MD-PCP, which is Maryland PCP. And Maryland PCP has another program, another arm of that program, which is called Johns Hopkins JMAP. So that's the Johns Hopkins program, and that's our particular registry that I've been working with. These registries tend to be broken down by county and then by service deliverer. Next slide. So this again is showing the model of collaborative care. So really the kind of the spoke in the wheel is supposed to be the health behavior specialist. They're a social worker or a case manager, but typically a social worker, highly trained social worker that engages, that is in, on site at a PCP's office, ideally, that engages with the local social worker, the case manager, the primary care doctor, and the health behavior specialist will engage directly with the psychiatrist. And the psychiatrist will provide guidelines and kind of tips to the health behavior specialist. The health behavior specialist will then go back to the PCP or the patient with those tips. So the health behavior specialist will start therapy, or if the case is too complicated, like if it's not a case of simple depression or anxiety or grief or adjustment disorder, but more like complicated psychosis, there will be an outside referral. So the health behavior specialist is really the person that everyone communicates with, and there's a lot of communication through the HBS as well. Next slide. So the referral process to get someone into this model is the PCP, the case manager, the social worker alerts the health behavior specialist that a consultation is needed, so that that a patient has its behavioral health needs, and then the HBS triages and decides, should this be an outside referral for a very complex patient? Like, should that patient go to a psychiatrist? Should the HBS then initiate psychotherapy for like a grief reaction, and the psychiatrist would have involvement as needed? So for example, an HBS would start therapy and the patient can't sleep, and the psychiatrist might help the PCP brainstorm some options for a sleep aid, or the HBS immediately would involve the psychiatrist and say, you know what, I think this is a patient that I should be seeing, but I also think that this is a case of kind of complicated depression that I don't think you should just communicate with the PCP about. You should really see this patient as well. Next slide. And that would be kind of co-located care. So I'm going to talk about a case where we tried to do it in collaborative care model, but where it really where the model of collaborative care just wasn't sufficient for this patient. So this was a woman who had incredible paranoid ideation, but she was resistant to care. So this is a 64-year-old Korean American woman who complained to her PCP of sharp leg zapping pain that she believed was coming from her husband in the past 2 years. Come in. So the patient had verbal outbursts towards her husband. In one instance, he pushed her after they had a fighting match, which led to an ED visit. And her husband, and it was disclosed that that was after she had pushed him. Her husband started living in a locked basement of their 4-bedroom home because he was afraid that she would hurt him. And he did not want to hurt her. Next slide. So some of the pitfalls in this case was that this was during COVID, and it was still everything was pretty much virtual. So the leg zapping pain was thought to be diabetic peripheral neuropathy. So there was a delay in the diagnosis of the fact that this was a somatic hallucination, meaning that she was having these feelings and that weren't actually true, that she was attributing to her husband. The patient herself was very resistant to coming in to visit. So she, like a lot of paranoid patients, a lot of psychotic patients, didn't have full insight into how sick she was. And so she would often miss appointments or not show up. Then because she was somewhat, she then accused her husband of pushing her after she had pushed him because he was, in self-defense. the staff became very split, and there was a lot of thinking that she was the innocent party and that her husband should be, for example, police should be questioning him. And so instead of focusing on her care, because of the drama of the situation, the staff at the PCP's office became very involved and very upset about the case. And then the patient actually, I did eventually emergency petition her to the hospital, and she got some psychiatric care. She was started on antipsychotic and did somewhat better after being in the hospital. But she needed a long-acting antipsychotic injectable, and she refused to go to an outpatient psychiatrist after getting her after her hospitalization. She just wanted to go to the PCP's office, and the PCP's office did not feel comfortable administering a long-acting antipsychotic, which is completely justified, as that's not a typical realm of care for them. So this case was someone who would not be appropriate for collaborative care, and really someone for whom care, even at the best psychiatry setting, is very challenging. Next slide. So this is another case that was somewhat difficult. This was a case of neglect and a case of a woman with a schizoid personality, or somewhat of an odd person. She was a 71-year-old female who lived alone, was unemployed, had no children, never married. The PCP social worker was involved because it was found out that she had faced eviction from her house due to foreclosure, due to years of unpaid bills. And her primary care doctor and office manager had difficulty contacting her, and she didn't answer. So basically, you know, they said, you guys are you have a better understanding of behavioral health. Can you please get involved? So we did the HBS did some outreach calls. She didn't answer. And then several months went by before she eventually came to the office to have an appointment. So she missed appointments because she was very evasive. Next slide. So these pitfalls were, you know, this is more about the way that providers feel about collaborative care. So the providers, including the social worker and the PCP, felt a sense of helplessness or hopelessness in terms of this woman's case. They felt as if they couldn't help her because she was resistant to care, much like the first case, and they couldn't locate her. But the patient's resistance to care made her case very difficult for anyone to properly help her, the PCP's office, and the HBS and the behavioral health office. So there is sometimes this feeling that if a psychiatrist asks someone the question, then maybe they'll get a different answer than the PCP will, because they have more skill in dealing with behavioral health patients. When the reality is, sometimes that's true, but oftentimes there's this kind of hope that if you involve psychiatry, then the outcome will be different. And sometimes it is, and sometimes these patients are just incredibly difficult and there is resistance to care. Next slide. So this is a case that I think is very appropriate for kind of a difficult case, but a case that was a very appropriate case for collaborative care. I personally took care of this patient, and I think that, you know, this was a success. This is a 52-year-old woman. She had a heart attack in 2010, and ever since her heart attack, she had ruminating thoughts related to her health. She catastrophized. She had a fear of getting sick, and every time she experienced any little sensation in her body, she became worried that it represented a terrible medical condition and she will have to go to the hospital again. Prior to her heart attack, she worked in the Baltimore City School District as a secretary. She loved working full time. Then she would come home, cook, and take care of her 3 children. She missed the way she used to be. Now, at the time I saw her, she received a disability from the school district because she was told she couldn't work. But even when she tries to get up and do a little cleaning around the house, she fears that she might pull a muscle and feel frustrated as though she needs to rest. Next slide. So, you know, the PCP referred this patient to HBS. And the reason is because it seemed like this patient had a lot of anxiety as related to her heart attack. So the HBS initiated therapy with the patient and formulated a diagnosis of illness anxiety disorder, or basically have a PTSD-like syndrome from having a severe medical illness. So she had the heart attack in her 40s, and that just basically made her feel unsafe at all times if she was going to have a repeat heart attack. And so I then was asked to optimize medical management for her. She was started on an SSRI, citalopram, and the PCP had given her as needed alprazolam, and I reassured her that that could be used as needed, and that there was no signs of diversion or you know, misuse of the prescription. Ultimately, the patient was referred to a self-help group because these encounters, the therapy encounters with the HBS, are supposed to be no more than 6 months, maximum to a year. So after, you know, a lot of therapy, the patient was referred out to a self-help group, and the PCP managed her citalopram and her alprazolam. I at one point was managing the prescription of the citalopram, but after a while that was on the PCP to do. Next slide. So this case was is a panic disorder case. This case, I think, is a very appropriate case. It doesn't have as good of an ending. However, this is another case I saw of a 74-year-old man with a history of a cerebellar stroke in September 2022, who was referred to psychiatry from his PCP. He had, you know, a plethora of emergency room visits for what was diagnosed as a panic attack. He was prescribed a medication for panic disorder, but it made him feel worse. This was sertraline, another SSRI. He was given meclizine for vertigo since his stroke, but it just made him feel worse. He was able to describe his stroke as feeling like all of a sudden he couldn't talk. But he, even though he often didn't feel like he was having another stroke, he just couldn't reassure himself that he was okay at home, so he would come to the emergency room. Next slide. So this patient, you know, when going through some of his ED visits on March 4th, he had some elevated blood pressure readings at home, returned to normal by the ED visit, but he had taken alprazolam before he came to the ED. He came in a few days earlier for headache and chills, you know, a couple of weeks before for nausea. So these non-specific complaints, and he had 18 ED visits from September, I think, through March. Next slide. Yeah, so thank you. So the diagnosis was, again, another case of illness, anxiety disorder, panic disorder, and alcohol use disorder in remission. And interestingly, when our team got involved, we said, okay, he definitely has illness, anxiety disorder, again, a PTSD-like syndrome of having another stroke. So we're going to send him to psychotherapy to do some kind of exposure therapy. We got this note, which is that client is a 74-year-old male who was here at the clinic after being referred by his primary care doctor. He was not quite sure about why he was referred or that this was a mental health care clinic. Once it was explained, he made it clear that he no longer wanted to be on medication. At this time, he does not feel he needs therapy, but would consider it later. And those were the therapy notes from Luminous Health. Next slide. So one of the things that we said to the, that I said to the PCP was that, you know, the patient had a lot of obviously very disturbing symptoms, but that he really couldn't see that some of this nausea or some of this elevated blood pressure was related to a psychiatric illness called somatic symptom disorder. So that's when people have a lot of different somatic symptoms. And the treatment for that is to create standing appointments with the patient every couple of weeks and tell them to collect all of their somatic issues until they meet with the PCP regularly. It does require a lot of work on the part of the PCP, but it may ease anxiety for the patient and save ED visits. So I always, like to offload some of the work from the PCPs to the psychiatrists. But some of these patients just don't have the insight that they need, that the etiology of their symptoms are psychiatric. So in that case, the PCP needs to be regularly involved, as this one was. Next slide. When I saw him the last visit, the PCP had been seeing him frequently, and the PCP asked me, please try and do something with him because he's still going to the ED. So we were able to talk about how the panic attack felt different from a stroke. So panic attack, he was uncomfortable, his heart was racing. A stroke, he lost his eyesight temporarily. He had loss of his voice during the stroke. So, we tried every time that he had symptoms, I said, look at what are the symptoms you're exactly having. If they don't fall into the symptoms of a stroke, try to avoid going to the emergency room if you can. If you really need to and you need to get something taken care of, absolutely do it. But if you can avoid it, that would be great. Next slide. So this is a case of a patient, a benzodiazepine case, which I'm sure PCPs get a lot. This is a 77-year-old male coming saying he was on Valium since he was 12. Which I don't think is possible because I don't think Valium was around since he was 12, but he presented to psychiatry after his PCP stopped Valium 1.5 years ago. So this patient was referred to psychiatry from the PCP. Per the PCP notes, patient was stopped because he was getting more than 90 morphine equivalents of oxycodone by pain management, and there was a risk of respiratory depression when opioids and benzos are combined. Since being taken off Valium, he reported going to the hospital countless times for increased blood pressure, the shakes, and panic attacks. And he did go to a psychiatrist and tried multiple antidepressants, including citalopram, duloxetine, escitalopram, fluoxetine, mirtazapine. He doesn't remember if any of them helped and said he got nauseous. And, he came in begging me for Valium, for low dose Valium, saying he was getting 5 milligrams twice a day, which is a relatively low dose, and saying that his quality of life was just terrible because he was a shut-in, he was irritable, he can't sleep more than a wink at night. And the PCP was really kind of wanting an expert opinion on should we prescribe this or not. Next slide. So in my, in my kind of pro and con list of how I thought about this. So pros, I did think Valium would likely alleviate his symptoms of irritability and insomnia. Of course, there's the patient dynamic component where if you prescribe it to him, he'll like me and I can get done with the appointment quicker rather than him yelling at me about not prescribing Valium, which is really bad reasoning, but it's part of what's going on in the dynamic of the visit. And then there was this thought that maybe he's right. Maybe he will have a higher quality of life if he's just able to get some sleep and not in so much pain. But then I thought, if I start him on it, what will another prescriber see things the way that I see them? Will they be willing to continue it? And what if he abuses it? So he says that he's never abused drugs, and I didn't see any escalation of the dose, but you never know. Patients are very good at hiding that. And then there is a fear about respiratory depression with oxycodone if he were to take, for example, all his Valium. Next slide. Sorry, go back to the other slide. So what ended up happening is I did give him kind of a trial prescription, I think like 5 milligrams twice a day for 30 days, and told him to come back in 3 weeks. At 3 weeks, he was out of the Valium. So at that point, he had failed that test, and his insurance changed. And so he couldn't continue with our clinic anyway. And looking closer into his chart, there were a lot of kind of short-term prescriptions for Valium, very similar to what I ended up doing. And I felt that that was, you know, very much a possible outcome, but tried to give him the benefit of the doubt, which sometimes works and sometimes it's probably not the right thing to do. Next slide. So these are some thoughts and conclusions that I have about collaborative care in general. So I think that some of the challenges we talked about might not be specific to collaborative care. Some of the initial cases I mentioned, the virtual environment of COVID made accurate diagnosis more difficult. I do think that primary care psychiatric patients may be even sicker than patients in a psychiatric setting, because patients who go to a psychiatric office at least have the insight that they need psychiatric care. If a PCP is seeing a patient and the patient is very psychiatrically ill but is not willing to go to a psychiatry, then there is that resistance to care and lack of insight, which makes treatment a lot more difficult. And then kind of the infrastructure of a PCP office, you know, most community psychiatry clinics can deliver long-acting injectables and other complex psychiatric treatments. PCP offices are not equipped to do that. So if you do have a psychotic patient who would need a long-acting injectable, it's probably best to get them into a community psychiatry setting. So I think the difficulty is both the model and the patients at times, but I do think the success of a collaborative care model for the patient depends on the relationship between the PCP and the psychiatrist. So when I go into a setting and I'm doing collaborative care, the people that I think of as my main clients are actually not the patients, but rather the PCP. I really want to get to know who the PCP is and what kind of prescribing practices they have and what kind of questions they're likely to ask, how comfortable they are with prescribing psychiatric treatment. Because if the PCP and I have a good relationship, then they can ask me questions, they can, you know, we can bounce ideas off each other, and that kind of results in such better care for the patient. So, you know, I think the relationships matters so much in collaborative care between providers. I think if you have the infrastructure for collaborative care, so if you have a health behavioral specialist who's willing to do a registry and create measurement-based care, it can work. Evidence is best for depression and anxiety. And yeah, those are my thoughts. Thank you.
Oh, fantastic. Hello, everyone. My name, oh, you can advance the slide. We'll do. Can I advance them or should I just say to advance them?
You can just say to advance them.
Okay, perfect. This is perfect spot. Hi, everybody. My name is Dr. Colleen Schrepfer. Really excited to be here to share a collaborative care model in an outpatient setting with you. I'm a child psychiatrist, also adult psychiatrist. I mostly see children and adolescents in the community. I'm also the senior medical director of Gladstone. I have no financial disclosures. Next slide, please. So I'm here today to talk to you about the collaborative care model, in particular, integrating mental health care services in an outpatient setting. Dr. Lepla's discussion was mostly about her experience working and being the director of this model in a healthcare system, Hopkins. And so my focus is more on private practices and how they can also be incredibly instrumental in incorporating a very necessary collaborative care model, which I will talk about today. I say that the model itself is extremely necessary and very needed. When we look at data from Hopkins, that they've done studies looking at the incidence of mental health challenges for our population, and about 1 of 4 adults are contending with mental health care challenges. And so 25% of our population. And when we think about that subset of patients, about 1 in 20 of those patients are dealing with very, very significant debilitating mental health care. And the collaborative care model, as we will talk about, is a way to kind of reduce those numbers and to reach patients who are not traditionally reached by the treatment as usual. So I'm excited to explore the objectives, which I have here, review why the collaborative care model is important. I will describe Gladstone Psychiatry Services, and then also I'll talk a little bit about Gladstone's collaborative model. I really would like you to think about 3 questions as I talk today. And one is for you to be able to list 3 benefits of implementing a collaborative care model, who was involved in the delivery of the model, and then what is a really fantastic gold standard evidence-based resource for exploring implementing this model and how you would go about doing that. Next slide. So there's been enormous research on looking at the collaborative care model, and there have been many, many models which have come about in terms of trying to figure out how to reach patients with mental health care needs. And so many models have been established, but research has shown time and time again that the collaborative care model in particular is a standalone model and really outshines many of the others. The research has started in the early 2000s, and I would say from 2000 to 2010, most of the randomized controlled studies, in excess of 90, were really developed to establish the benefits. And clearly there are enormous benefits for patients, for providers, and for the cost system as a whole. So the collaborative care model is really the gold standard. The studies since 2010 have really been looking at collaborative care model is the gold standard. How do you do that? How do you implement the strategies in maybe different settings? But there is an enormous body of research out there. Next slide. So let's look at what's come out of the evidence that started in 2000. And as you can see here, enormous benefits. And I'll only, again, this is a short 15-minute talk. We could probably talk about this for hours, and there's an enormous body of literature out there, but I'm just going to focus on some of the highlights that I think are relevant for us. So in terms of looking at improving public health outcomes, again, collaborative care model research has shown that it makes an enormous difference in reaching the patients who need help. And ultimately, having access to mental health care, the outcomes are significantly better. Many of the studies compare the collaborative care model to TAU, which is treatment as usual. And in most of the body of the literature, there is a significant improvement in outcomes with time to initiate treatment, the amount of time necessary to get to symptom reduction. In particular, there was one study that looked at, again, collaborative care model to treatment as usual. And the collaborative care model, a patient reached a diagnosis and initiated treatment within 6 months of reporting their symptoms. And 75% of the time, most of these patients experienced significant improvement. Compared to treatment as usual, where less than 25% of the patients who were referred for mental health care actually sought it. So you're catching patients with a collaborative care model earlier, and they're reaching symptom reduction much quicker. And we're significantly losing an enormous body of patients who are reporting symptoms and not getting care. One of the other challenges is that some of the data that has looked at overall mental health care, and on average, it takes 11 years for someone to reach treatment per the treatment as usual model, 11 years from symptoms to actually getting care. lots of things getting in the way and lots of hurdles for someone being able to get that care, but it's clear that the collaborative care model reduces those barriers for patients. And when we look at the total reduction in care, the total cost of care, we are looking at, there are upfront costs to setting up a collaborative care model. I didn't go into detail on that on here. There's a resource that I'll talk about later that describes things very clearly, but there is an upfront cost to kind of setting up the EMR, setting up a registry, setting up ability to kind of track patients who the primary care doctor is treating and seeking support from mental health services. You have to think about their screens that have to be put in the EMR for patients to track their, the GAD for anxiety and PHQ-9 for depression or other scales. So there's a cost to kind of setting that up. And then in terms of interoperability between the primary care and the psychiatric center, and then also data collection and staffing and education. So there's a big upfront cost to kind of setting it up, but once you set it up, time and time again, the research clearly shows there's a significant reduction in overall cost of delivering the care. Blue Cross Blue Shield of Michigan has implemented the collaborative care model, and what they found is that when they did, again, collaborative care to treatment as usual, that there was a significant treatment, especially for patients with depression, remittance of symptoms within 16 weeks compared to treatment as usual, which was 52 weeks. And when we think about the time to get to that care, the length of time the patient is holding those symptoms and how that affects them functionally, relationship, work, everything else, the collaborative care model in this study done by Blue Cross in Michigan was a 2 to 3 overall time reduction in cost of delivery of care. And there are other studies that have looked at for every dollar of investment in setting this up and thinking about, again, all of the things that I mentioned, the upfront cost for every dollar that you put into setting up a system like this, you get a return of about $6.50 per every dollar that you invest. The other element that we need to talk about is improving provider satisfaction. And, when you think about the knowledge transfer that goes from someone who's trained in psychiatry to a primary care provider, there is therefore not only with this one patient they're collaborating on, but then the knowledge that's learned in collaborating with a specialist in this area, then that knowledge transfer impacts the other patients in the practice as well. Again, thinking about that delivery of effective and meaningful care. And, the other thing that we need to think about in terms of patient satisfaction with overall care is getting care sooner. If you look at Maryland's map, and you can do this nationally, but we're talking about Maryland here. These are our patients. When you look at the map of Maryland, there's a rural health hub that kind of gives you an idea of the number of mental health specialists who are available in specific counties. And when you look, there is a swath kind of from Baltimore County, kind of all the way down to, Anne Arundel, where I would say for the most part, there is a maybe sub-adequate presentation of the number of patients to the number of mental health care providers. The only county in which there is a healthy, wealthy relationship to the number of mental health providers to patients is in Montgomery County. Then the next level down, where there is still a need, but it's not a complete absence, is that swath that I mentioned from Baltimore City all the way down to Anne Arundel. But if you look at Garrett County on the far western part, and then if you look at Cecil County on the far eastern part, there is a significant lack of mental health care. And so when you think about the absence of psychiatrists and nurse practitioners who specialize in this, it's really important to have this collaborative care model to reach these patients. Telepsychiatry since COVID has helped reach some of these patients in rural areas. But again, that's treatment as usual. And as I've demonstrated, treatment as usual is incredibly delayed compared to the collaborative care model. So in terms of patient satisfaction, getting the care, finding you don't have to do the next slide, sorry. Finding someone who you can trust and get the care you need more quickly. And so the other Oh, go back one more, sorry. So if you want to look at some of this data in much more detail, if you look to Unitzer et al., they did fantastic studies in the early 2000s looking again at the evidence. Next slide. Another fantastic study was done by Garrison et al. In 2016, and they had a very powerful study, and they looked at almost 7,400 patients with significant depression and dysthymia, cared for at 4 different outpatient primary care clinics using the collaborative care model. Again, collaborative care considered versus treatment as usual. Median time to remission of symptoms in the collaborative care model was 86 days. And in the treatment as usual group, 614 days. So it is a significant, almost 7 times length, 7 times from treatment as usual, which is 7 times longer to get the care that you need. So you have conclusions from this study that are profound, are that, it demonstrated that patients enrolled in the collaborative care model have a faster rate of remission and shorter duration of symptoms than patients who choose treatment as usual or usual care here. Next slide. I want you to, if you're going to take a snapshot of anything of the slides that I have today, this is important. I would say that of all of the settings across the country who have spent time, and most of these are educational centers that have looked at models to deliver mental health care, the University of Washington has the gold standard, and here is their website if you want to get information about what collaborative care models look like in other settings potentially. Again, we're talking about primary care here, but there's utility with oncology and obstetrics and gynecology, college campuses. So this is a fantastic resource, and they have a wealth of knowledge, and it's very user-friendly. And so I highly recommend that if you're interested in diving in deeper, please use this website. What makes the collaborative care model feasible is that in 2017, Medicare established 99 codes for paying for the collaborative care. And on average, in terms of thinking about setting up a collaborative care model, so from initiation to completion is anywhere from 3 to 12 months, depending on the size of the system. Next slide, please. I'd like to talk a little bit about Gladstone. We are the largest outpatient psychiatric group in Maryland. We accept insurance. We accept commercial insurance. We have 5 locations as listed here. And here are the commercial insurances that currently we accept, that we have contracts with. We are not a Medicare or Medicaid provider. Currently, we have 30 psychiatrists and nurse practitioners, 22 therapists, and 12 certified DBT therapists, and we're growing. We have clinical leadership in areas of addictions, women's health, LGBTQI+, child adolescent, crisis management, and eating disorders. We do conduct telehealth since COVID. And along with in-person, probably 90% of our patients are seen through telehealth. And so with that, we've been able to kind of get the outreach in far west and far east of in Maryland, outlying counties. And I'm proud to say that when a patient calls, we have evaluations available within 3 weeks of calling. Next slide, please. We do offer this is a full Marsha Linehan, who developed DBT certified program where we see adult, adolescent, and child cases, and this is only through CareFirst, so it is covered by insurance. We do have individual therapy for all commercial insurances for kids as young as 5 all the way up to adults, and of course medication management for all. We do have advanced diagnostic screening from a psychologist here. It is not neuropsych testing, but it's more very specific screening and a battery of screenings that are developed specifically for the patient to address treatment-resistant challenges and more guidance for the therapists in particular. We do have a psychedelic-assisted psychotherapy program. Currently, ketamine is our current pilot study. We just completed the first pilot and very excited with the data that we have from that. These are all patients currently right now who are Gladstone patients. And we're starting a second pilot in July, and we're hoping potentially to open it up to all patients in the community in the fall. And again, this is not delivery of ketamine and that's it. This is very important to have the psychotherapy component with ketamine. So we're very proud to offer that. We also have TMS that will start this summer. And currently it is the traditional TMS delivery. We are hoping there's a Stanford Saint protocol in which the length of time to deliver TMS is going to be shortened significantly to a week. And so this is not the traditional TMS where it takes weeks and weeks and weeks to be able to have the full treatment. This is something that can happen in a week. So it is less disruptive of lifestyle. You can take a week off and have full treatment. So we're excited about that. Hopefully the Saint protocol will be approved this summer. Next slide, please. Our collaborative care model currently is we are working with a pediatric office in Frederick, a primary care office in Timonium, and also starting to work with an oncology practice where we have a Zoom once a month and a psychiatrist in that area of specialty. Again, I'm child adolescent, so I'm doing the pediatric office consultations. We open up Zoom and the pediatric office, any of the providers there can log on and ask any clinical questions. And with that, we're able to offer recommendations, not only for medications and treatment changes in that regard, but also therapy and community resources. And this is also something, again, we're very pleased to be able to do this with the oncology practice. The future goal is for Gladstone to actually have a case manager. Dr. Lepla, and I'm sorry you were unable to see her lecture, but in that she did talk extensively kind of about the collaborative care model, what that looks like. For psychiatry, it would be, we would present a case manager, and most of the cost is on the primary care practice to kind of set up the infrastructure. And in the next slide, I can talk a little bit more about the model. Okay, so this was not something I was going to talk about because Dr. Lepla talked a little bit more extensively, but here there are many images that kind of relay this relationship of, the patient is the center of everything. And within that, you have the case manager, primary care provider, and the psychiatrist. And in most of the collaborative care models, it's that the primary care office connects with the case manager who's associated with the psychiatric practice and presents questions about treatment-resistant patients, about medication side effects, about next steps, about therapeutic interventions. The case manager, who is someone who has a bachelor's degree, health background, potentially a nurse, a social worker, someone who's an addictions counselor, who has the knowledge, and also someone who also has some collaborative experience previously, then would ask the psychiatrist or the nurse practitioner about the case, who would then relay information back to the case manager. And that is the general flow. There are some potential changes, but in general, that would be the flow in the outpatient setting. So again, most of the costs would be at the primary care office. The case manager would be hired by the psychiatric office as the interface. Yes, I see a question popped up. That is the plan for our practice. Again, we've started with opening up Zoom for discussion, and next step would be we're actually talking to Care First about that now, about setting up a model such as that. And then I won't go into, no, we are not a practice that has Medicare or Medicaid. We're only commercial insurances. Okay, next slide. Here are our locations. Next slide. And I wanted to give you resources for how to contact Gladstone by email. Also, we have a website. We have a presence in the community with a social media footprint. We have Instagram, Facebook, and blogs where we have a DBT certified therapist who presents on a weekly basis general information about psychoeducation or mindfulness practices or resources. And so it's been a wonderful resource for us to kind of outreach to the community. And I thank everyone for your attention.
Thank you, Dr. Schrepfer. So why don't we go back to Dr. Schrepfer's questions for consideration that we started with? So can you go back a few slides to, I think it's our second slide. Keep going back, but yeah, one more. Yeah. So some of the questions are, some of the benefits of implementing these models and, who's involved obviously in the care delivery and what's an evidence-based resource. But what I'd like to hear from is a little bit around from the audience, a little bit around some of the benefits that they see of implementing one of these models. I know we have a lot of systems and a lot of primary care practices on the line today. So is anybody interested in discussing the benefits to them for working in a collaborative care model? So we have a couple questions coming up in here. There's some about the insurance, about the Medicare and Medicaid. Someone asked, would you work with a social worker versus a case manager? That's for you, Dr. Schrepfer.
Absolutely. And there is training involved, as I mentioned, having someone with a bachelor's degree, having someone with healthcare knowledge, and having a nurse or an addictions counselor, a licensed clinical social worker would be the ideal individuals for those case management roles. Absolutely.
Great, thank you. So do any practices of Dr. Modermass, please, welcome.
Hi, welcome everybody. We have done collaborative care. We started with just psychiatrists in a pilot in our practice around 2016, and we've implemented collaborative care since, well, I guess in January of 2019 is when you actually could start billing for it. So we've been doing that now for several years in our practices, and the benefits are amazing. To find resources for your patients for psychiatry and for counseling is very labor intensive and can take hours for your staff. So this is not completely, I'd say 90% remove those barriers, because Medicare is still a barrier, and Medicaid, we could not accept Medicaid patients until the last month. So prior to that though, now everybody, so not Medicare, but Medicaid and our private payers, I mean, it's just huge. It takes so much time off. It's that conversation where you're getting ready to leave and somebody says something and that's going to take you a lot of time to work that through. So I can't say enough about collaborative care. We did pre-post analysis. We saw significant reductions in total cost of care and utilization, significant improvements with anxiety and depression. And happy to be a resource if anybody would like in the future. But I just want to let you know, it's really meaningful for our practice. And most people said they couldn't live without their collaborative care model in their primary care practice. Thanks for the opportunity to speak.
Yeah, thank you for sharing that with us. And these are the stories that we love to hear about how this is happening. And I do think, a lot of people are doing this and getting this similar feedback to what you're getting. So does anyone else want to come on and talk about the collaborative care model that they're using in their practice? Anyone else interested right now? Okay. So again, thank you. So we're going to move on to Dr. Bahithi, who is a primary care doctor, and I'm going to let her introduce herself, but she's going to talk about how the collaboration works from a primary care perspective. So if you could advance a few slides to Dr. Bahithi's slides. Yeah, there you go. Thank you very much.
Thank you. Good afternoon, everyone. Thank you for having me over today. I am Dr. Bhavna Bahithi. I'm primary care, internal medicine, adult medicine provider practicing in Glen Burnie, Maryland. We are a two-provider practice, and we're part of MDPCP MedChi, which is a model, as you all are aware, designed to coordinate the care of patients, improve health outcomes, and also attempt to rein in the rapidly rising cost of healthcare in Maryland. Next slide, please. So a few questions sort of to consider with is in primary care, what is the mental and physical health? What is the connection? What is this costing us both monetarily and in terms of patient outcomes? And how do we meet the needs of our patients? So piggybacking on what Dr. Schrepfer has said, in primary care, almost 10 to 40% of our patients have some diagnosable mental health disorder, but usually present with physical complaints, headaches, poor sleep, fatigue, pain. And the cost to the healthcare system is tremendous, both monetarily and in terms of patient outcomes. Emergency room visits, almost 40 to 50% of high utilizers have underlying mental health issues that has contributed them to repeatedly go to the emergency room to seek care, and contributes to poor health and also poor patient satisfaction. Also, with the newer reimbursement modes with value-based and capitated plans, it becomes even more imperative to take care of a lot of our patient needs at the primary care level as much, and try to seek the help of additional support and assistance. And that's where the collaborative health model has sort of come in. Next slide, please. So as a primary care, we see our patients, we identify them with need who need additional behavioral health needs with screening tools, mostly during their annual wellness visits, during their yearly physicals, but also if there are some symptoms that warrant that. Once that is reviewed with the patient, and this is in the background, we have longitudinal relationships with patients. And so once we have identified that there could be some other additional assistance with the behavioral health, mental health assistance, we talk this over with the patient, confirm with them, they agree to receive the services, and then we, we establish closely part of the MDPCP MedChi association closely with the behavioral health specialist. And this has been invaluable in getting the patients good care that they need in a timely fashion. So at the office level, we complete any consents, any of the referrals, fax them over to them. And then from there on, the behavioral health team has been great in taking this over and contacting patient and trying to take care of them from there. Next slide, please. So again, from the behavioral health specialists, and they've been this has been invaluable, as Dr. Scheffer has pointed out. In our area, we are sort of somewhat underserved with mental health, and we do have enough resources around the area, but wait times could be months to get in. And again, during this time, we see the patients deteriorating, their blood pressures are not under good control, their diabetes is not under control, they've had multiple hospitalizations. And so we're trying to do something to help intervene, to help and assist the patient. Our team has been great to us. We have a licensed clinical social worker. I can always pick up the phone, talk to her directly, explain to her what exactly is going on, which is, again, would have been hours of trying to find someone else in the community, and often with unsuccessful results. But from there on, they sort of take over and engage with the patient. They have been very successful in coordinating with patients to get a treatment plan, provide the appropriate psychotherapy, of course, but also coordinate a referral to a psychiatrist if medication management is needed, or feedback to the primary, either me or my nurse practitioner directly, so they can call me and say, hey, it looks like this patient might benefit from additional treatment, so on and so forth. The other big one, and again, we've been indebted to MDPCP MedChi, because this has been really such a blessing, because they have been able to assist us with giving us the social work team and the behavioral health specialist team has been able to give us community resources, so we can refer the patients ourselves to start with, while they do the wraparound with the other mental health assistance, etc. At the end, the biggest benefit also we find is the feedback that we get from the mental health. And I know sometimes we work in sort of vacuums between the mental health, the primary care. We're sort of trusting what the patients tell us when they come in, but they're not sure of what the treatment plan might be. So this has been great, where we actually will get a report back with the patient's reports, what the progress has been, what their needs are, and what their treatment and the status of their services, et cetera, are, whether they're continuing to engage or not. If they're not, when they come back to the office, we'll kind of discuss and say, what were some of your concerns? If they say, we don't like the fact that their office is located in a further away, the telehealth has been invaluable for those patients. So again, because we have different ways of touching the patient for their mental health needs, it has really improved and expanded the availability and the benefits of the behavioral health specialist. Next slide, please. So a couple of case studies, and these are, actual patients who we've sort of, communicated, talked over with our specialists. So it's a female patient in her 70s who has been navigating grief and significant stress. She lost her husband. She's having some family stressors going on. She was also having some problems with her memory because of that. So some of it we weren't able to determine how much could be more anxiety, stress-related memory, but also giving her additional support to actively manage her grief. So we did talk to the behavioral specialist, send a referral over. They were able to contact and communicate and had a established sort of appointment schedule. And that has really helped to help her building coping skills, trying to look at additional resources that are available to her. And for her, memory and the confusion, we continue to experience difficulties. So the behavioral health specialist, because I think she was reluctant initially, she couldn't find a specialist to help her. So the behavioral health specialist did work with her to encourage her, or sort of piggybacked on what we have already discussed in the office, to say it's important, go ahead and make that appointment. If there's any problems, get back to your primary. So it was sort of an additional reinforcement. And so that helped with supporting and encouraging her to take directions in the right manner. Also, what are the additional community programs to help her out? So that sort of she joined the senior center, and she had a few other things that kind of helped with getting more sort of more out socially and able to take care of herself. She's improving every time we see her. There's improvement. She's working still actively working with a mental health therapist, and having challenges, but it looks like she's in the right direction. Next slide, please. Our next patient is a male who's in his 70s. He's been a longstanding patient. So we sort of have a little bit of longitudinal follow-up with this patient, and the staff and I noticed in the last several visits, he had been sort of withdrawn, not sort of participating. He was usually pretty gregarious, greeting all the staff, and he was not being his usual self. During his annual wellness, and that was another thing that part of the MDPCP program, MedChi program, we've been able to develop additional in our EMR different ways to look at these assessment tools. And so, part of that was his PHQ-9 had significantly changed from his last couple of ones that he had before. So, on delving further, he did mention that he was the caregiver, and he had got additional responsibility, that although he was, retiring, but he was taking care of his 95-year-old mother, and additional stress of taking care of his own household and some family issues that were going on. So we sort of talked to him, and I said, looks like there's a change. His blood pressure was out of control. And so even in spite of various medications that he was taking, and he did express he's not been really taking good care of himself, eating, exercising has not been as much because of all these different directions he has been pulled in. So We did talk to him saying that it looks like it may benefit to talk to someone because, and initially he was a little reluctant. "Oh, I'll take care of it myself. I don't need to. I'm fine." But I think once he came around to it, he did really feel that connecting with the mental health therapist helped him in identifying his own health, how to focus on things to take care of himself better. And we saw the results. His numbers improved, his blood pressures were better, he had lost a little bit of weight. And so I think working, simultaneously has helped him with we're aiming for, trying to help with his medical conditions, but also his mental health addressing did help him to improve his overall health outcomes. So this is where, we're finding that this collaborative health system has been invaluable. And I think the more I see, the more I'm feeling, very strongly that is the way, because so much of our medical health is related to our mental health. So we're sort of really trying to incorporate that more and more, and hoping to see this in other areas and other insurances and other sort of spheres of medicine. But this would be sort of for me, that was kind of my share. And if there's any other questions, please go ahead.
Thank you, Dr. Bahithi. Can we go back to her questions that were right after her section slide? So she talked a little bit about the mental and physical health connection, which Dr. Modermast talked about before. But does anyone want to weigh in on some of the things about like how much they think this is costing in patient outcomes, or how they're meeting the needs of their patients? Would anyone in the audience like to talk a little bit about this? And we've heard the stories from Dr. Bahithi, but does anyone from the audience want to weigh in today? Let's give you guys a minute to. Dr. Shrepfer, do you want to say something?
Sure. I think it's incredibly important, especially when we think about the lag time. Again, kind of collaborative care versus treatment as usual. And in that lag time, which was 7 times longer for some of the treatment as usual, we think about how mental health care, we know the connection of mental health care and physical health in terms of immunocompromise, thinking about cardiovascular, thinking about diabetes, but it's also about lifestyle too, and it's about choices. And we know the relationship between untreated depression and anxiety and untreated ADHD as well, and addictions and substance use, how it impacts our relationships, how it impacts our function at work, the choices we make, the inability to kind of choose healthy lifestyle, be able to sleep and exercise. So it's just the repercussions are incredibly powerful. And then the inability to make good choices for yourself then further worsen the mental health part. So they're inextricably connected in a very powerful way.
Wow, thank you so much. That was great. Thank you. Okay, so you can take the slide deck down. Dr. Pusinello is going to present her slides for us, and she will do a brief introduction in just a second. Hold on, I think I need to make you to share slides.
Do I need to hit share screen?
Yeah, but I think I may need to make you a co-host first. Okay. There you go. You should be able to share.
Can you see my screen?
We can see your slides.
All right, so I'm waiting to see if I can see them. Oh my, there we go. Let's move some of this away. All right. So I am Hogan Pusinello. I'm a psychiatrist in private practice on the Eastern Shore of Maryland. And I'm really happy to be here. I've been tracking collaborative care, haven't become a collaborative care provider yet, but my specific interest is in how relevant something I do, I believe is for collaborative care, and I want to tell you about that. So the questions I want you to put in front of you would be, what might be the impact of improving heart rate variability, peripheral skin temperature, overbreathing, or prefrontal cortical function in your patients with stress-related conditions? These are all typical targets that are accomplished with biofeedback and neurofeedback. So my goal is to help thought leaders and clinicians come up with innovative ways to add these modalities into our medical practices and psychiatric practices. I've been in the practice of psychiatry 30 years, and 15 years ago, I learned about and added neurofeedback and biofeedback into my practice. And what has amazed me is that I can have a direct effect on brain and body physiology through operant conditioning. These are long-standing modalities. They're efficacious, they're safe, fairly inexpensive, fairly easy to learn to use, and can be administered by techs, nurses, parents, and sometimes patients themselves in the waiting room or at home with guidance. Yet they remain almost unavailable for patients. So the innovation would be figuring out how to get it to them. It's not a new modality. So given that the US is experiencing an epidemic of stress-related conditions, and that we are being asked to deprescribe, to avoid adding medications for the elderly, advised to avoid polypharmacy, we have minimal options for TBI, yet how are we supposed to deprescribe and use minimal medications? Because neurofeedback and biofeedback work by improving body and brain regulation, they're potent not just for stress-related conditions, but also generally good for wellness and resilience. And regarding medications, they can often lead to less medication or resolve symptoms without additional medications. In my experience, right away, I saw that neurofeedback felt like an anticonvulsant because it had such broad and stabilizing applications. Also, these are low stigma. So we have an advantage with these modalities that some people will enter into treatment through a more attractive backdoor of optimum performance. They are long used in school performance, sports performance, performing arts, and they can improve general self-regulation, reduce reactivity. It's beyond the scope of this presentation to review the research, but my website has information and I added slides in this presentation that you can look at. I'll suffice it to point out that the Mental Health Association of Maryland, our own advocacy organization, published in 2021 a comprehensive neurofeedback research update and analysis, finding neurofeedback to be efficacious. The Kennedy Forum in 2015 found that the primary barriers to the adoption of these are lack of awareness by practitioners. That's why I'm here. And lack of access to the biofeedback devices, which are very affordable for physicians. And one of the most exciting new resources is the 4th edition of Evidence-Based Practice in Biofeedback and Neurofeedback, published in 2023. It listed 42 of the syndromes commonly encountered, not just in psychiatry, but in primary care, like hypertension, asthma, headache, migraine, diabetic control, immune function, as evidence-based, and gives the research, summarizes the research. The evidence is plentiful. We've had AMA-approved CPT codes and FDA approvals since the 70s. The codes have not been well maintained, I think mainly because of the lack of interest among physicians and the lack of funding from the manufacturers of these modalities. They don't have the money that drug companies have to promote themselves. So to introduce you further to these modalities, I want you to just take a quick look at these pictures, thinking about how is brain performance related to behavioral health. Powerful control and skill needed here, excellent timing, endurance, reliability, and resilience. That's what we want in brain function around mental health issues. Good performance requires a well-regulated brain and body. Most of that regulation is highly unconscious and highly learned. Our brain, of course, is like this times a billion, with people throwing wet rags and towels into the audience and tackling the jugglers. Our brains have to handle so much. So what happens when we're not well regulated? We're more like this. We start to wobble cognitively, emotionally, and we're prone to wiping out. Our brains are in charge of so much. What if we could strengthen regulation in these areas through a learning modality, through operant conditioning, using biofeedback and neurofeedback? Neurofeedback and biofeedback are stabilizing, like adding a tail to a kite, but they also lead to strength and endurance of that self-regulation because they're like lifting weights, exercising, like learning. It takes repetition to grow that strength. So what I use in my practice are EEG neurofeedback and passive infrared hemoencephalography. It's a mouthful. It's a neurofeedback measuring infrared output from the prefrontal cortex. And I use peripheral biofeedback for heart rate variability and hand warming. So I'm going to explain these briefly. I'm just going to give you some basics about biofeedback. We collect a body measure of a physiologic function. We give the participant feedback. Then the patient learns to control the signal. And that learning translates into improved function of that physiologic system. Normally, we're not aware of our heart rate, skin temperature, or muscle tension until it's out of whack. It's all unconscious as it's getting out of whack. And then we experience pain or other disconcerting symptoms. We measure all these things in medicine, but we don't generally think of using biofeedback to change them. So once we measure, we provide feedback, audio, visual, tactile. The patient is unaware of his EEG behavior normally, but he's actively changing it in response to the feedback. We're using a conscious window into an unconscious physiologic function. And then we're changing it through operant conditioning. The functions associated with the area and parameter targeted improve with enough practice. So let's just look at heart rate variability. Most psychiatrists stop with normal sinus rhythm. Heart rate variability is looking at that rhythm over time. We all remember keeping an eye on the fetal heart rate as the first sign of distress. Heart rate variability predicts development of hypertension in the healthy. It predicts survival after a heart attack. It predicts higher risk sudden death in the general population. And it's a better predictor of long-term cardiovascular health than blood pressure, cholesterol levels, resting heart rate in healthy individuals. So a good question would be, I wonder how my heart rate variability looks. Or why aren't we utilizing the biofeedback, to actually improve heart rate variability in our patients? Heart rate variability is done using an ear sensor that you can plug into an iPhone or a more sophisticated biofeedback device. And then we use the patient's conscious attention and coaching to their breath and have them watch the reading of their heart rate variability. The top line here reflects a patient whose heart rate variability reflects a stress state and a quick breath pattern, shifting to a slower, below, softer breath. The clinician or tech coaches the patient and encourages practice. So you can do this you can introduce a patient in a single session, have them back 3 to 10 sessions, depending on how well the patient learns and how motivated they are to practice at home. And they can practice just the skills at home. And when they come back to the office, plug in, see how much better they can make their HRV. Or they can have a unit at home and progress more quickly. The more they practice, the quicker they will get there. There's much more in the realm of peripheral neurofeedback that can apply in the clinic setting. We can provide feedback with a respirometer that shows us the quality and frequency of breath. We can use capnometry to identify and correct overbreathing. Overbreathing is not always easy to detect, but it's associated with panic, anxiety, and poor stress response related to many chronic stress-related conditions. And temperature training can be very useful in bringing down blood pressure, overall anxiety. It can help with pain. This is a simple $25 hand warming tool called the stress thermometer. We coach patients on how to attach it. We educate them. Really, we use very systematic and diligent coaching as key. We ask the patients about their practice. We ask them to chart their practice. We stress practicing under ideal conditions, just like you go to basketball practice in ideal conditions before you learn how to play basketball in the game. There's a lot of coaching. We especially insist on eyes open, first of all, so you can see the feedback, but also because eyes closed relaxation training, which is what most therapists I know do, is not the same as practicing relaxation skills with your eyes open. I send patients home with tip sheets, ask them to graph their process, and check on homework. EEG neurofeedback is fairly simple. We use 2 computers. One the therapist looks at, one the client looks at. We put a sensor on the head. And then we're training the patient, the area of the brain that is most related to the symptoms that we're trying to improve. You might ask, how can neurofeedback be like an anticonvulsant or target such a large range of symptoms? It's because where we train the brain determines the function affected. It's difficult to tackle these problems unless you address the brain directly. Some areas have very specific benefits, say in vision or attention. Others have broad effects on arousal or executive function. Again, that's the reason that it can have so many effects, because there are lots of brain regions. Even affecting one node of a brain network can affect the whole network. This is the kind of screen I would watch. It's what I use to set the reinforcement schedule or difficulty level. I'll just point out for you to notice the raw EEG. It's kind of high. And then beneath, we're filtering out the brain waves, and you can see that one of the inhibits has very slow, large waves. It's those waves that are making that EEG look dysregulated. Here's a normal looking EEG, small in height. So we're essentially asking this particular patient to reduce the tall, slow brainwave activities at that site on his brain. Normal EEG, the brain is more in tune in that area, more alert, focused, calm, efficient. An excessive slow EEG causes you to work harder. The brain is less efficient. It's like the kid wobbling on the bike. This is just another example of excessive slow waves and a better regulated EEG. This is an alert, awake brain. This would be the feedback screen that the patient watches, where each of those EEG parameters that we're trying to train are represented here, and the patient's told to push the middle forward, the tube on the sides, pull those chips back. Another form of neurofeedback, one I particularly enjoy watching patients respond to, is PIR-HEG. The target here is the prefrontal cortex, which we all know works by inhibition. So when we target it, it's like adding that tail to a kite. Patients gain more self-control. It's particularly potent with classic migraine, post-concussive symptoms, and reactive patients. It's helpful in situations, especially where patients are excessively responsive and overly an excessive rate and magnitude of their response to relatively benign stimuli. Training the prefrontal cortex to become dominant with reliability, strength, and endurance can improve symptoms. The prefrontal cortex controls all these things. Lots of the disordered behaviors and functions that we see in our patients are associated with problems of regulation in the prefrontal cortex. That's what I'm seeing in our journal articles, where there's, whether it's trauma or post-concussive symptoms, that we need to improve the strength of the prefrontal cortex. It's the part that makes us human. It's the parent in the room. So the patient with this one just wears a headband with an infrared camera. They watch a movie until the movie pauses. And at that point, the patient is instructed to shift their attention to the measure of their infrared function and to intend to improve that measure by quieting their mind. So that's the simple screen that pops up when the movie freezes, and they have to get that blue bar up past the yellow bar. So we will give them some conscious methods and coach them, but really the brain is experimenting like somebody trying to turn the light on in the basement. And the patient is noticing, they're up in the attic, noticing up, down, and they need a quiet mind. So they learn a conscious approach, but the actual effectiveness is through an unconscious physiologic function, learning. So I wanted to show you a few images. This is a normal infrared image. This is a patient with depression. Not all depressions will look like this, but makes sense. Left frontal lobe, right? That's where we do TMS, ECT. That's after a single infrared session, maybe 5-7 minutes. This patient has raised his infrared output, which reflects metabolism. This is a week later. So if you look back, started out like this, comes in like this a week later after that session. Now this one is the baseline another week later. So he held on to the improvement even longer. His brain is already learning, and after just 3 sessions. This is a woman with anxiety. This is immediately after her first session. This is a week later. So again, she holds on to some of that improvement. This is the baseline 5 sessions later, a week after her last session. So essentially, the learning is based on practice with enough lessons and learning. We're hoping the patient changes their physiology and that their baseline improves and there's more unconscious flexibility, adaptability, and resilience. So the take home is these are safe modalities. They're potent. They can target brain regions and specific physiology, and they are established medical and wellness treatments, evidence-based. Thank you for this chance to present.
Thank you, Dr. Passanella. You have a question. Is this kind of evaluation and treatment covered under most insurance plans?
I would say that Medicaid is the one that covers it most reliably. I've had some patients get authorization through special case agreements. What we really need is advocacy for updating of our codes, which have been neglected for years, partially due to what I said before. Physicians at the CPT code meeting have to advocate and vote for better codes.
So Medicaid has covered it, but the other ones haven't necessarily covered it.
I think Blue Cross Blue Shield will cover neurofeedback for some situations. I'm in private practice, so generally my patients pay out of pocket and then I submit the insurance for them. Sometimes I can get a single case agreement to cover neurofeedback.
Okay. Does anyone have any additional questions for Dr. Passanella?
One thing I would mention is that because techs and nurses can help administer this and patients can learn to self-administer, that's how I've helped some patients to afford it whose insurance didn't pay.
That's a great point. Thank you so much. So Dr. Bahiti is asking how much is the outpatient? How much is the out-of-pocket cost for the patients?
Well, the outpatient cost, if they're seeing me, is my usual fee.
But if you just set them up and they did it at home,
if they do it at home, there's only the cost of renting the computer and the system. So if patients need to get 2 of these a week or 3 a week for 40 sessions, they might do 1 online with us. But I've had patients who would do 4 sessions before they do another one with us online. And in that case, they pay nothing to us. And they pay, I think it's a $99 fee a month to rent the software. They have to have a dedicated computer for the software. So it's a reasonable cost for patients that are capable of home training. My fantasy, of course, is to have a sets of equipment available where patients can come in, sit down, and train themselves with a little bit of help from a tech who's supervising others. And that needs a medical system, a clinic to provide.
Okay. Are there any other questions for Dr. Passanella? Okay, great. So if we can just bring up the closing slides, please. So I want to thank all our speakers and all of you for coming today. What I will try to do is when we post the recording, I will try to add in Dr. Lepla's slides because I think it was a really great presentation. I'd love for everyone to hear it. I'm sorry that the video quality, the audio quality on the video wasn't working very well today, but I will try to add that in when we post our slides. So again, special thanks to Dr. Shrepfer, Dr. Bahithi, and Dr. Passanello for their input today. So the way we do this is we post all the slides and the recording onto the MHCC website. Everyone will be receiving a questionnaire in the next couple of days. We do ask you to fill it out to receive your CMEs or CEUs. So unless someone has any questions, I'm going to close out and wish everyone a very happy weekend.
Thank you.
Thanks, everyone.
Thank you.
Have a great weekend.
Bye.